So my name is Steve Larowe. I'm a clinical psychologist. I earned my PhD at Florida State University in 2002. I did a postdoc at the Medical University of South Carolina, not to be confused with the University of South Carolina. Those are separate entities. Did a 3-year postdoc in addictions. There's somebody there. Come on in. Hello, hello. Then I stayed at the Medical University for 16 years as an adjunct, and meanwhile I started working at the VA doing substance abuse treatment. I've been doing substance abuse treatment for about 11 years, so about 16 years of expertise in this area, and then almost 11 years in the VA system. I was in Charleston for 10, and now I'm here at the James H. Quillen VA. Is that all right? I'm sorry if I didn't give you a chance to talk. All right, so the historical context. There remains no FDA-approved medication for cocaine dependence, despite the fact that there was a large amount of federal support back in the late 80s. There was this sort of argument that cocaine use was associated with HIV, and that allowed us to get the will to fund this kind of work. And back in the 80s, it was generally known that dopamine was involved in the addictive processes, particularly the stimulants. And so dopamine. Hey, dopamine is involved in schizophrenia. Let's do antagonists, agonists. Let's do some clinical trials to see if that helps with addiction. But the clinical trials of dopamine agonists and antagonists were conducted, but none were effective. And a result, after numerous costly and lengthy studies, no treatment for cocaine dependence was identified. And that was I really kind of feel like when you look at the literature, you get a sense that people were sort of throwing these medications at it because there's money to do the research, and not a lot came out of it. And you might argue that back at that time, we didn't have the ability to really integrate across disciplines as effectively because we didn't have this immediate web access. We didn't have our journals online. When I was at Michigan State, you had to go to one computer that you had to sign up for an hour to look up studies. So perhaps part of this is because we didn't have the communication going on. And so we started talking about the translational approach. In the 90s and the early 2000s, there was this emphasis on coordinating basic and clinical science, the bench-to-bedside translational approach, with the idea that you have basic science, really doing good experimental control, and experiments that could be conducted relatively quickly, actually extremely quickly compared to clinical trials. And then you also were able to have a better sense of basic findings that revealed information about basic mechanisms of addiction in a way that we couldn't do in humans. And it allows for a more efficient discovery and screening of candidate medications. If you do this rigorous screening, then you have a better idea if this is a likely candidate for efficacy, and you don't have to do the big clinical trials. So having this basic science research, come on in. So, welcome to our folks who are, I believe, our applicants for the residency program. All right, so I hope that having this talk can demonstrate how you have some really great educational opportunities here at ETSU. What you missed is that this is a talk about how we're improving our development of medications for addictions. And we're going to be talking about a substance called N-Acetylcysteine. And what I was what I was doing with folks was telling them we were kind of throwing dopamine agonists and antagonists at people with cocaine dependence in the 80s to see if that actually get them to quit cocaine dependence. And largely that didn't work. And so the NIH started talking about, let's coordinate our basic science researchers with our clinicians so that we can screen more effectively and efficiently candidate medications for addictions. So we're not sort of haphazardly testing medications for addiction treatment. That's what brings us up to here. So screening medications for using basic science methods in the laboratory with animals allows us to maybe determine if a medication is even worthy of going on to a human trial. So this brings us to the story of N-Acetylcysteine. This is definitely a story where I don't know that we would have even thought about N-Acetylcysteine as a candidate medication if it weren't for the basic science. So this is the bench to clinic journey. In order to move forward at this point, it's important for us to have a very basic general overview of the addiction circuitry. Obviously, we didn't evolve to be addicts, but the addiction circuitry is essentially the survival circuitry that's been hijacked by addiction. And a particular structure of great importance is the nucleus accumbens. This is kind of like an integrative relay center that receives projections from the ventral tegmental area, from the amygdala, from the prefrontal cortex, takes this information, and then sends out projections to other structures to initiate motor behaviors and intended to initiate behaviors to acquire reward. So all of the research we're going to talk, or all of the research we're going to talk about at the basic science level occurs in the nucleus accumbens and how that seems to relate to actual drug-seeking behavior in animals. So if you look at the animal literature, you can see one of the predominant paradigms, not the only one, but one of the predominant paradigms for cocaine-seeking behavior, to model cocaine-seeking behavior, is the reinstatement paradigm. And what is involved in this paradigm is that you basically train a rat to press a lever for cocaine. Actually, there's a tube that goes around here and goes into the jugular. And every time the rat presses the lever, they get a hit of cocaine. They get this light to pair with the cocaine. And then you test how many lever presses the rat gives you in a 2 to 6 hour session. So this is, you're going to see a lot of these charts that say lever presses. This is an indicator of cocaine-seeking behavior. And if they get a consistent level of lever presses, we basically consider that rat trained to self-administer, and it's actually supposed to be, we've now kind of created a rat addict. And then what happens is you do this extinction paradigm. You have no more programmed consequences for the lever. And as a result, the rat will press the lever for a little while, and over several training sessions, 2 to 6 hours, it basically gives up. And at the end of that, it'll kind of look like a rat in recovery. Fairly normal. It'll look like rats that aren't addicted or self-administrating for cocaine. But if you give that rat a little bit of a priming dose of cocaine, or once again display the cue that's been associated with cocaine, in this case the light, you now start to see a resumption of the behavior. The behavior is now reinstated, and you start to see lever presses that are coming back. And so that's kind of what we suppose that relapse looks like. This is a very nice face-valid model. One of the advantages of animal research is, of course, we can actually do some very specific measurement of what's going on in the brain. We can put these probes into the brain and actually sort of insert it into the accumbens and see what's going on in terms of neurotransmitters, function. We can put in specifically designed substances to activate certain receptors and see what kind of effect that ultimately has on behavior. So one of the things that was discovered when this research started is that glutamate activity in the accumbens is involved in reinstatement. I mean, we've all heard about how important dopamine is, but we're also learning that glutamate is important in initiating a lot of drug-seeking behavior. So I told you that you have projections coming in to the accumbens. So you have your presynaptic projections. You've got your postsynaptic cells, or the postsynaptic neurons, sending out projections from the accumbens. And what is found is if you activate these receptors, you see behavior, but if you block them, you see reinstatement is blocked. And here you can see active lever presses during reinstatement. Once they put in an AMPA antagonist, a glutamate antagonist, reinstatement didn't occur in those particular rats. So we really know that glutamate, not just dopamine, was an important pharmacological target in cocaine-seeking behavior. So that's cool. How can we develop things to maybe make that happen in humans? Well, there's still more story to tell. In addition to preventing reinstatement by blocking glutamate postsynaptically, there was also discovered that in these rats that had been chronically treated with cocaine relative to rats treated with saline, there was a lower basal level of glutamate in the accumbens, lower basal level. And when you gave them a priming dose of cocaine to set off the reinstatement behavior, you see this exaggerated response of glutamate. So there's something about the low basal levels that's associated with higher release of glutamate. It's almost kind of counterintuitive. Nevertheless, when you do this, you see that these rats are showing a robust response in extinction or a reinstatement, and these rats here are not. So you've got lower basal levels associated with greater release of glutamate, associated with greater pressing for cocaine, although in reinstatement they don't actually get cocaine when they press. They're still doing cocaine-seeking behavior. So, just to sort of review, what's going on in the accumbens with glutamate is if you've got enough basal level of glutamate, you have enough glutamate to bind with receptors on the presynaptic cells. And here you see this is going to be a very important autoreceptor because when you activate that, it can slow down and regulate the release of dopamine when you have a cocaine challenge. So unfortunately with cocaine, you see the lower basal levels. I'll show you that in a second. I wanted to show you that this discovery here was also done by my colleagues in the basic science area. In fact, all of the basic science that I summarize is done by our basic science group at the Medical University of South Carolina. Basically, they demonstrated that if you activate this mGluR23 autoreceptor, those presynaptic receptors, you do see a nice reduction in reinstatement behavior. And so we need to have sufficient tone at the basal level. We need to have enough glutamate present to keep activating those receptors, to keep regulating the release. So this kind of re-demonstrates that once you've got cocaine-related reduction in basal glutamate, we don't have enough glutamate here to keep these activated. And as a result, when the cocaine prime occurs, you get this big, huge release of glutamate binding to your postsynaptic receptors and giving you a heck of a lot of response. And that's what we think is going on when they're reinstating. So the question becomes, can we actually restore these levels to reduce cocaine-seeking behaviors, or to at least reduce reinstatement? So how do we do that? Well, if you look around in the glial cells surrounding the synapse, you recognize that there is the cysteine glutamate antiporter. It's an exchanger. And what this is, and those of you who are medically trained are probably more aware of this than I am based on my training as a psychologist, is that this is a plasma membrane-bound, sodium-independent anionic amino acid transporter. I feel like I've just memorized how to say something in another language without really knowing what I'm saying, like I'm singing an opera or something. But what it essentially does is it exchanges extracellular cysteine for intracellular glutamate. So also in the accumbens, you've got some cysteine kind of in the synaptic areas and in the outside of the synaptic area that's kind of present. So these exchangers are ubiquitous throughout the body, including in the glial cells within the accumbens. So this gives us a nice little target to see if we can actually make those basal levels normal again. And just to show you how this works, you've got your glial cells that have these exchangers. These green dots are meant to represent cysteine, and you put in a cysteine and out comes a glutamate. And so as this happens, you are now restoring your glutamatergic tone at the basal level. Same group, same folks went and tested this. What if we started to manipulate the exchanger? If that happens, can we create lower basal levels, and can we reverse it? So here you've got your cocaine-treated rats. They have that lower basal level of glutamate. You've got your normal rats, and if you stop exchange, you can bring down their levels of basal glutamate. And if you go back and you have your untreated rats and your cocaine-treated rats, if you put cysteine into the accumbens, you can actually enhance exchange and bring those basal levels back up to normal. So now this is really exciting because now we have a very specific target and actually a very specific thing we can do to actually make things happen. Let's get cysteine into the accumbens. Maybe we can restore the basal levels, and maybe that will stop reinstatement. And what that does is bring us to N-Acetylcysteine. This is, I'll call it NAC. It's a well-known medication. It's already FDA approved in humans for other indications. And we know that what that means. It means that it might be a candidate for off-label use, right? I'm all right to say that. What N-acetylcysteine does is ultimately converts to cysteine, and when you systemically administer it, it'll raise the basal levels of glutamate in the accumbens in rats. This is a study that looked at this, and it actually does it pretty rapidly. At these doses of 60 and 600, they were able to raise the basal levels of glutamate within a 4-hour period. So what does that look like? We've got our N-acetylcysteine providing us with, it readily sort of converts from cysteine to cysteine. We now put it into our synaptic areas. We get the exchange, we restore our basal levels, and we have nice opportunity to put tone on these mGlu-R23s. We see a reduction in the amount that's released. So far, so good. So they went and they tested that directly. So here's the lower basal levels of glutamate, and you give a saline injection, and as you might expect, nothing happens. Then when you do your cocaine prime, you see this exaggerated release of glutamate relative to baseline and a corresponding response in reinstatement. So that's the normal activity. But when you induce NAC, or when you introduce NAC, you see that you have a restoration of the basal glutamate, and when you do the cocaine prime, the glutamate release relative to this basal level is lower, and you see a corresponding block in terms of the reinstatement. So again, really exciting. We can put N-acetylcysteine in, restore basal glutamate, and see a reduction in reinstatement behavior. So that's where we were, the state of affairs, when they came to us and said, hey, let's look at this in humans. It's NAC, old dog, new tricks. Already FDA approved for Tylenol overdose, cystic fibrosis. So it's a drug that's well known. It's not a Franken drug. It has very mild side effects. You see nausea, vomiting, diarrhea. We know all that. It's just sort of the garden variety stuff you see for any new drug. The ones that really come, that are really common and what you're likely to experience is a stomach ache and flatulence. So aside from those relatively small inconveniences, it's a well-known drug. It's very safe. And you can even buy it over the counter in health food stores. You can get this at GNC. And what's nice about that is it's going to take us less time to take it to trial. And if it's effective, it's a cheap medication that people can use to potentially treat their addiction. I think it's about $15 a bottle, 60 pills, 600 milligrams. That gives you a 1,200 milligram dose for 30 days, 2,400 for $15. For $15. For $1 a day, you can have something to help you with your addictions potentially. Some of you may know about this process of drug development for the FDA. There are several phases, 1, 2, and 3. And phase 1 is usually the safety studies where you demonstrate that stuff is safe enough to take. And then oftentimes it's required to do an interaction study. So in cocaine-dependent individuals, what they'll do is they'll bring you into the hospital and give you a cocaine infusion. They'll give cocaine addicts cocaine and the medication to make sure they can tolerate both at the same time. Now, parenthetically, it's easier to give a cocaine addict cocaine in the hospital than it is to smoke a cigarette in nicotine addicts. Can't get a cigarette to happen, but you can give cocaine. I thought that was pretty fascinating. Fortunately, since NAC is well known and very safe, we were able to skip this interaction study and do an open label trial. This meant that we had people who were out there using cocaine but also taking the medication, and then we could see if there were side effects based on that. So I'm going to describe 3 studies that we have done. We were able to do this one, and an initial preliminary efficacy study. So this NAC to bedside process involves getting your IRB approval. If anybody's done research, you know that that doesn't necessarily happen over a weekend. That can take several months. Then you have to go to the FDA and get an investigative number. So there's a back and forth between yourself and the FDA over and over again. That can take a while. Then you've got to get something called a certificate of confidentiality so that when these people report their cocaine use, you can protect their records so they can't be subpoenaed. It took us 6 months just to get the first inpatient safety study off the ground. And then we really did, 15 participants on an average of once a month. So it took us a while to get this initial safety study done. And compare that to animal studies. They can do a whole heck of a lot within a couple of weeks. And so that's the nice thing about basic science. It can tell you stuff very quickly. Takes a lot longer to do it in humans. So in these studies, you're going to see people overwhelmingly male. We have a lot more ethnic diversity in Charleston, so we had a lot more African Americans, not a lot more than Caucasians, but there's certainly almost, well, it's a majority really. 40 years old approximately, 13 years of cocaine use, 20 years of alcohol use, about a third of them were alcohol dependent. They had to be healthy, free of medications, and free of a history of asthma or seizure. So in phase 1, again, we're looking at safety. But we also did something called a cue reactivity paradigm. Cue reactivity paradigms is a way to test medication efficacy in humans, where you show them pictures or movies or paraphernalia and see if they have reactions in terms of craving and interest and physiology. And the idea is if you see a reduction in that, maybe that's a signal that the medication's doing something. Now remember, this is not an interaction trial, so everybody had to be clean. You couldn't have a positive urine for cocaine to come into the hospital. It's a 2-week, double-blind, placebo-controlled crossover design, which means 1 week you get placebo, you come back the next week for identical procedures and you get the active medication, or vice versa, and you don't know what you're getting and we don't know what they're getting. So they'd come in on a Tuesday night, be there Wednesday, Thursday, leave on Friday. We gave medications every 12 hours, 4 doses, and on this second full day, we did this cue reactivity paradigm. And that was one of my specialty areas because I used to do psychophysiology. So before I tell you about the cue reactivity results, I also want you to know that we did 7 ratings of sort of what their moment-to-moment craving was, and took a snapshot. So this is just their craving as they're sitting in the hospital over 7 occasions. And so we basically did this every 12 hours, and then we subtracted our baseline scores from each post-baseline rating to see if there's a change. And we summed those, and what we found is a very small result that suggested there might have been a significant drop in craving over time in the NAC group relative to the placebo group. Not a compelling finding, but a nice little signal. And then we looked at our inpatient cue reactivity. This was a little more fun. All 15 participants viewed the slides. There were 5 cocaine, 5 neutral, and 15 emotional slides. They could view the slides for up to 20 seconds. And they could turn the slide off at any point before that 20 seconds had expired. And then they did ratings of craving, desire to use, and ratings of interest. So you'd see pictures of cocaine, and even now when I show this picture to folks with whom I'm doing groups, they'll look at it and go, oh, holy moly. This is actually simulated cocaine. And then you'd show maybe household objects that aren't all that compelling. I was really quite floored to see that the participants looked at cocaine slides for less time in the NAC condition. What's really nice about this is not a self-report measure. This is a behavioral measure of interest. And you can see they were pretty much equal in terms of their response to neutral, but you see this lower amount of viewing time in our NAC folks. Similarly, with interest and desire to use, You saw a reduction in interest and a reduction in desire to use in the NAC conditions relative to placebo. Not in craving, but in terms of these other measures that capture similar, that have overlapping, that has an overlapping meaning with craving, we did see the differences there. So the summary was it appeared to be safe, a trend for reduction in tonic craving, reduced time for viewing slides, and reduced interest and desire to use in response to cues. So that gave us enough positive results to get small grant funding to move on to our open label trial. I'll kind of go over this very quickly. We had NAC at 3 doses, very small sample sizes here, but we're really interested in seeing if they could go out, take this out in the community and not have really bad side effects if they were still using. Did it over 4 weeks, variety of measures, craving measures, use measures. And basically what we found is we had mild side effects, even at the higher doses. And all kinds of other nice little findings, including better retention at the higher dose. People who stay in the trial did better, and they generally reported a reduction in craving. But these findings are not atypical of pilot studies that are open label. You know, people think they're going to do better when they're on a medication. They're going to report they do better. So really, your bread and butter is your placebo-controlled trial, which is what this phase 2 trial was. 8-week double-blind, placebo-controlled outpatient, 2 dosages along with placebo, 1,200 and 2,400. We gave them some weekly manualized treatment, 3 weekly visits with study personnel. Ultimately, after we screened folks and got compliance data, we had 111, about 35 in each group. No effects for NAC on confirmed days of abstinence. I went through every participant's data, counted their days of abstinence, and if they had a corresponding urine drug screen that was negative, I'd give them credit. No differences. But no effect on cravings. 3-way interaction, I started to sort of look at all kinds of different things. What if I look at different baseline levels of use? That doesn't look very encouraging. Not really anything going on. 3 years, now what? I was a little disappointed with this. So, took a step back and started to take a closer look at what is it that our basic science really told us. And I think the dialogue between basic science and clinical science has been somewhat limited in the past. So basic science will say, here's a medication to try for treating cocaine dependence. And clinical science will say, great, we'll take it from here. Basic science is okay, let us know what happens. Clinical science, 3 years later, that didn't work. So, is this the end? I don't think so. This is where we have a new and improved dynamic process of integrating basic and clinical science. When I did my postdoc at the medical university, it was a unique experience, and they were so nice to let me do this. But I was able to go across the street and sit in on meetings and have conversations with their basic science people, and then go back and have conversations at meetings with their clinical people and go back and forth and back and forth. And so we really had kind of a very dynamic dialogue. So maybe the dialogue should be integrated a little bit more effectively. I mean, we see that this previously was a bench to clinic approach, but keep in mind that their basic science folks identified a medication following their established procedures, which was the reinstatement paradigm. As clinical scientists, we tested the medication using our established procedures. Here they're looking at relapse prevention. Here we were looking at achieving abstinence. Everybody was pretty much taking cocaine. We were trying to give them the medication and see if they stopped using. And we couldn't do it any other way because we had to do the conventional methods in order to get funded. So because cocaine dependence has proven to be such a resilient problem, I thought it would be nice to coordinate our research efforts a little bit more in a detailed fashion. Like I was telling you, back and forth and back and forth. So let's keep in mind the reinstatement paradigm. I went back and I kind of read what the paradigm looked like. I read these animal studies. And in this paradigm, your self-administration is kind of like the human version of ongoing use. Your extinction is treatment or maybe abstinence in humans. Your reinstatement is the relapse or return to use. Basic science was focusing on this one. Clinical science was focusing on this one. All of our positive findings were in this circumstance, not necessarily in that circumstance. So, if we had an improved dialogue, it might sound something like this. Basic science. We have a medication that prevented reinstatement. Clinicians are like, what's reinstatement? Basic science. It's a model for relapse. We train, withdraw, extinguish, reinstate. The medication prevents the reinstated cocaine seeking after rats are withdrawn from cocaine and it went in extinction training. Clinical science. So it makes NAC makes you stop using. Basic science. As far as we know, this medication works when cocaine is withdrawn and there's some sort of relearning in terms of extinction. So it only works for those who have stopped or had some sort of extinction, but what about those folks that haven't stopped? Does NAC work for them? Basic science. It appears effective in our models for relapse, but not for reducing use or achieving abstinence. We'll need to test that a little more because they only did a very basic analysis of whether NAC had an effect. What they found, again, the clinical question is, will medication make you stop using? Will cocaine administered here stop this behavior? The answer is no. The initial landmark study didn't find it, and follow-up studies didn't find it either. So as a clinician, we might conclude that clients that are unable to initiate abstinence or still not using cocaine on a daily basis might not benefit. And look at what the study I showed you had a negative result. Well, those people were actively using. So if it doesn't work in animals, it shouldn't work in humans either. So as a clinician, I wonder, okay, now, do I have to do the therapy? I did these manual-based sessions. It looked like you guys did some extinction training. Do I have to do therapy to make NAC work? Well, actually, extinction improves NAC's effects, but NAC can still block reinstatement if administered to animals having undergone abstinence only. So I could take a rat, not do extinction training, put him in his cage for 10 days, and NAC will still work. So that tells me as a clinician, maybe I don't have to do therapy. I don't want to put myself out of business. So I think what we're trying to get to is abstinence. And it's the necessary and sufficient condition to make NAC work. And maybe my behavioral intervention really has to focus on getting that abstinence and then giving them the NAC. Maybe we could use contingency management. That's the thing where if you come up with the negative urine drug screen, you get a prize. You do a drawing, you get some sort of reinforcer that way. What about drug-free housing? We've got Oxford houses. At our VA, we've got the domiciliary with a lot of folks who are not using and can't use if they're going to stay in housing. So let's go back to this idea of relapse, reinstatement. Standard clinical trials, like the ones we did, are not designed to assess for relapse. They're designed to assess for achieving abstinence. But what happens if we look at abstinent individuals in our recent trial? Interestingly enough, in all of the cocaine studies that had transpired before, you had to be actively using. You had to give us a positive urine in order to get into the study. And I said, well, that's not what we're doing in reinstatement. And so I went to my boss, Dr. Malcolm, and said, what if we allowed people to come into the trial even if they didn't have a positive urine? So these are presumably people that are cocaine dependent but might have stopped using a little bit. Let's take a look at them. We had 17 people. What we found was NAC seemed to reduce relapse. This is a nice sort of dose-dependent finding. Placebo folks relapsed more quickly, 1,200 in the middle, and people at the highest dose took longer to relapse if they relapsed at all. This finding pretty much took a negative trial and kind of saved it. So I was really relieved when that gave us a little something. And then we go back to this idea of craving. Prior studies found that NAC-related craving involved some form of abstinence. The two studies that, this particular study here, the safety study and the cue reactivity study, those people weren't using. So what happens if we look at craving in these people who are abstinent? Well, ta-da, we see that there is a nice reduction in craving as a result of NAC use in these people who are abstinent. So what does that tell us about NAC? When do you use it? When people are abstinent. You're not going to get a lot of luck if they're actively using. So Prior studies found that NAC-related craving reduction involved some sort of abstinence, and the results that we have here, you had to have abstinence for craving to work. All right, a little bit more. One of the things I noticed in all the previous reinstatement studies is they got 1 dose of NAC before they were tested for reinstatement. 1. When you do a clinical trial with humans, do you give them 1 dose and send them on their way? No. They're on a medication regimen, on a daily medication regimen. So I asked, animal studies usually give 1 dose. Will NAC work if administered chronically? Believe it or not, even though I wasn't a basic scientist, they let me go into a laboratory and start giving NAC chronically. And interestingly enough, I wasn't a basic scientist, but I was the first to do it. I'm not saying I did a very good job. I'm just saying I was the first, because immediately the basic scientist went, okay, and went and ran like 5 studies before I could finish my 1. But what we found is that it actually hastened extinction. You see a faster drop in behavior of lever presses in the extinction setting if they're on NAC versus if they're on saline. Not super compelling, but it's there. So what we have is chronically administered NAC enhances extinction learning, and subsequent studies also have shown that it blocks reinstatement and has a lasting impact afterwards. If you give NAC over a long period of time and then wait a certain period of time and still do reinstatement later, it still has a positive effect in blocking reinstatement. And about this time then, after talking to these guys, I went to the big head honcho, the PI, and said, we should do it this way. And I was lucky enough for him to actually listen to what I said, and he went out and had all of his folks do that from here on out. So now they do it chronically and not acutely. And I think over time, because they did this, they started to realize that that exchanger I told you about before isn't actually telling the whole story. What they've started to have to do is to account for the positive effects. And that led them to take a look at these glutamate transporters that are also in glial cells. This glutamate transporter just sort of works like a vacuum and sucks in glutamate out of the synapse. And when you have cocaine on board for a long period of time, these are downregulated, and you don't have as much removal. But if you put NAC in there, it somehow restores these glutamate transporters, and you get your regulation again. It's not as simple as the exchanger story with cysteine, but what we think might be happening is what's leading to the downregulation of both the GLT and the exchanger is oxidative stress caused by cocaine. And since NAC can sort of ameliorate oxidative stress, that's what we think might be going on. Now, I just asked the PI, Peter Kalivas, a couple of days ago, and honestly, they don't exactly know how that works. They just know that when they put NAC into play, these guys come back, and you see a reduction in reinstatement. So that's where we are now with NAC. And then the question becomes, how does it work with other substances? If you go look at the literature, there's a lot of promising findings, but they're kind of mixed. They have looked at it in marijuana, and they found that with adolescents, if they did contingency management, and they gave them prizes for being clean, and they gave them NAC, you saw a lot of good reduction in marijuana use. Then they went into a multi-center trial. They have these clinical nodes, NIDA has them, and they did it with adults, contingency management, and they consider that result to be negative. On the other hand, if you take a closer look and you break out the participants, Caucasians and non-Caucasians, you saw a nice effect for NAC in the non-Caucasian groups. We don't know why that is. We still have some more figuring to do. Interesting backstory, the principal investigator here is a friend of mine, and he was doing marijuana work, and one day I just sort of wandered in his office and said, well, since there's a common endpoint in addiction, maybe you should look at NAC in marijuana. And he said, okay, I'll do that. And that's what started all this. It just goes to show you that sometimes these hallway conversations can lead to good things. They're doing some work with nicotine. There's a lot of little studies. One will be positive, another will be negative. It seems to be tipping more towards the positive side. And there was work in methamphetamine. There were 2 small trials, mixed results. The first trial was negative. The second trial was positive. But if you go back and take a closer look at those 2 trials, The first study was an abstinence trial. They couldn't achieve abstinence, but the second study was a relapse trial, and that's the one where we saw the positive results. Again, going back to the idea that maybe NAC should be used for relapse. So to summarize what I've had so far, animal studies show abstinence is necessary and sufficient condition for NAC to work. Human studies have effects for NAC in conditions of abstinence, so NAC is probably best for relapse prevention. And with the dynamic interplay between basic and clinical science, it's advanced our understanding of NAC considerably, and I think is a pretty good model for how we want to move forward when we're developing medications for treatment. As a result, we now have a fairly good understanding of the mechanisms underlying NAC's effects, and we also have an understanding of conditions in which we'd expect it to be maximally effective. So where do we go from here? I'm still invested in this story, even though I've been out of the research game for a while. Right around 2004, 2005, money for research just bottomed out, and people who were very accomplished researchers weren't getting funded, and it's still very difficult to get funded in this day and age. And I think the will to fund for cocaine, they're like, we did this for 10 years, we're out. That's what NIDA basically said. It still might be something worthwhile to look at as a medication for relapse prevention. Maybe we want to use contingency management to induce abstinence, then administer it, or maybe we want to get folks that are in drug-free housing and give them NAC. We have this as an opportunity potentially at our VA. We have NAC on the pharmacy. It's in liquid form, which I'm not sure how to use that exactly, but it's like super cheap. It's like pennies on the dollar to give this medication. And so I think we have a nice opportunity to see how this works in the addiction population we have here. The bad news is there's not going to be a phase 3 multi-center trial for NAC, and the reason is that private industry doesn't have an opportunity to make money on it because it's readily available, and that's just how it works. A lot of these drugs go to trial because there's the sort of the financial will by private industry to fund these trials. And they have to make a profit if they're going to do it. And that's why you don't see a lot of these generics that are used for other indications, like gabapentin is used for alcohol withdrawal, but you're not going to see it probably FDA approved because no one's going to do the multi-center trials. So that's bad news, but again, NAC is pretty safe stuff. So some of the providers that I knew affiliated with the medical university were trying it with their folks who are fighting addiction. I want to say also, since this is relevant to this audience, is that there's also a lot of work now looking at NAC as an adjunct to treatments for other psychiatric treatments. I think it's used for trichotillomania. They've looked at it for OCD. They looked at it for pathological gambling. I think they're using it as an adjunct for depression. So these are all kind of preliminary trials. We haven't seen big trials, but it's kind of out there. And if you want, you'll probably be able to do a quick review and find some of the review articles that discuss this. One of the things that kind of discourages me a little bit is that right now, of late, there have been more reviews about NAC than there actually has been about clinical trials actually testing NAC. And I think there's like 3 different reviews out right now recently that look at NAC as a treatment for addiction. So, acknowledgements. The fellow that's the big kind of head honcho at the medical university for the basic science, his name is Peter Kalivas. I got to say, being able to sit in an office with him and have him explain things, he had a way of explaining it that made it very accessible and very exciting. And to watch a mind like that work is a really fun thing to be able to do. And he was very open to my suggestions because I wasn't directly his student, and he respected the fact that I was a clinician. And then Dr. Robert Malcolm, he is a workhorse at the medical university in terms of doing drug trials, and he also is a very supportive and very open-minded individual. In fact, they were kind enough to allow me to be first author in a lot of these papers, and so if you do a NAC review, you're probably going to see my name in there, and it's because of people like this that I had those opportunities. One of my colleagues who eventually became a psychiatrist, she was involved. I was lucky enough to get onto a training grant, and I was lucky enough to actually get funding for my own training grant, which was very cool. I put that out there, and it got funded right away. It's the last grant I ever got that was funded, but after the money fell out, it was hard to get more. And we had some pilot funding in the General Clinical Research Center. This was a nice opportunity here. That in our main hospital at MUSC, they actually had space set aside to do this kind of research, which was awesome. I think that this talk is going to be readily available if people want it. And I want you to know that the references are there if you're so inclined to go back and read them. It's all there for you. So with that, I'll conclude the talk and say thank you for listening. Thank you for missing the Christmas parties to come and hear what I had to say. Questions? Yes, sir.
So Topiramate has been looked at in cocaine dependence, Ben Colby-Johnson and others, and it actually is a glutamate receptor antagonist and GABA receptor agonist, and has been suggested to initiate and maintain abstinence. So trying to put that together with your talk, one idea might be that a GABA receptor agonist might be initially helpful in establishing abstinence through down modulation of the dopamine pathway.
Yep.
And ongoing, the glutamate receptor antagonist activity of topiramate might help maintain the abstinence against subsequent stimuli to use.
Yep. And I think, I'm a little rusty, I think we looked at topiramate in alcohol dependence. They did not do, as far as I know, they didn't do screenings for topiramate in their animal studies. And if I remember correctly, there's quite a few cocaine trials that have looked at GABA agonists for cocaine. I think baclofen was one of them. And what you're going to see is a lot of trials with sort of a preliminary success, but didn't translate into bigger trials. But I wonder if it might be a situation where they're also trying to test this medication and trying to achieve abstinence as opposed to being used as a relapse prevention agent. And that might be where we get some traction.
Yeah, I haven't seen it separately tested for relapse prevention.
Yeah, that's the thing, and that's typically not a paradigm that researchers have used in the clinical setting. So I would have loved to see that. We wanted to test acamprosate for this too because it seems to have glutamatergic properties, and it just went when the funding fell out, they just pulled the plug on all of that stuff. And then the attention in the NIDA, not only did the funding go down, but NIDA started to turn its attention to nicotine, and now opioids are going to be the focus. And so the will to do cocaine and even methamphetamine is lowered. Yes, sir.
I have a question, maybe an observation, depending on your answer. The reduced glutamate we find in the brain dialysis studies, have you followed those animals to determine whether they restore spontaneously?
That's a great question. And one of the things that sometimes was frustrating to me when I was working with the basic science folks is I'd have questions like that. Not that particular question, but I'd have questions like, for instance, not all rats reinstate, not all rats develop self-administration. So I'm curious about what's different between those rats that do and don't.
Yeah, that was sort of related.
Yeah, and
as a consequence of this, what if the glutamate reduction is adaptive? Glutamate is excitotoxic and causes brain damage. What if raising it in the presence of cocaine is the absolute opposite of what you need to do?
Oh, so so one of the frightening things about increasing glutamate in the accumbens is not only the aspect of being neurotoxic, which I'm not aware of the neurotoxicity of glutamate in the studies that are done in that regard. And again, I think that's one of the gaps in the research they're doing here, because they're excited about moving forward, but they don't answer these kind of questions. One of the questions I had is, well, if you're increasing the glutamate level, aren't you risking risking activating those postsynaptic receptors? And isn't that a risk? And at one point, the thinking was, well, maybe if NAC is at too high of a level and there's too much glutamate, maybe that's going to have the opposite effect. And that, I don't know what happened to that narrative, but it's dropped out. And there's this focus on the GLT now. It's interesting. I think it depends also on the training dose, to what extent NAC can have positive and negative effects. If I can find my proper slide, and I hope this is pertinent to our conversation. But in this, where's my extinction study? In the extinction study, I found that NAC actually seemed to potentiate cocaine-seeking behavior if you were trained at a higher dose. Their initial studies had, gosh golly darn it, where the heck is it? Here it is. That's not it. I don't know if you'll, oh wait, there it is. Okay, take a look at this. And again, this isn't about the neurotoxicity question as much as it is if you put NAC and increase the glutamate too much, maybe bad things will happen. So at a low training dose, you gave NAC an extinction and it goes down. But at the higher training dose, you put NAC in, you're actually seeing a bump up here. Kind of goes along with the idea that I'm introducing perhaps some glutamate and increasing the behavior, but ultimately it came back down again. So I wonder if that pertains to your question of sort of the spontaneous recovery of glutamate levels.
I was a little concerned about those lines too. They don't look different to me.
With these down here? Statistically speaking, they were, but you're right. There doesn't appear, the question is whether that's a meaningful difference. But they have subsequently gone back. This was my kind of unsophisticated attempt to do this, but they've since gone back and done many studies that replicated this essential finding. So I certainly want to hang my hat on a study done by a clinician who's just starting out. But I will say that there have been plenty of studies to come back and to reinforce this idea. Other questions?
Well, just relating to that, so one possibility is that there could be a biphasic kind of effect of glutamate. So if you raise it beyond a certain point, you might see neurotoxicity mediated through NMDA receptors and calcium influx, which is a well-known mechanism of neuronal cell death.
And I wish I had the opportunity to put that bug in the ear of the folks that are doing this kind of work. I will say this, they also have started to move away from N-Acetylcysteine and look at some other substances. And they're starting to ask questions about maybe it's just easier for us to block the postsynaptic receptors and what substances will be available for that. And then is there going to be bioavailability in the brain? And they've looked at ceftriaxone. I believe I'm saying that right. Am I saying that right? Ceftriaxone? It's antibiotic. And they did this kind of work with ceftriaxone and found some really positive results. But trying to get that into the human brain, you know, how to do that? Did they have to inject it? They could not find a palatable way to get that in there. I'm sure that partially but not completely answered those questions, but I hope I came close. Are there others? So one question that people aren't asking that I want to just throw out there is opioids. There was some preliminary work. The fella that saw me do this ran off with this and started to look at whether NAC would help with heroin addiction. Initially, it looked like we were getting some comparable results, and I think that, but that hasn't seemed to have gone anywhere. So I'm not sure that NAC's going to really do much for opioids in human populations. So to be continued. And that's really, I think, where the will to research is. So we shall see. Okay, thank you for your attention.